Hello, my name is Zachary Shumaker. I am presenting a case of a patient with cerebral palsy who used an intrathecal Baclofen pump who presented to the ED with obstipation that mimicked an intrathecal Baclofen pump failure. I was assisted in the creation of this presentation by Dr. Dave. This case presents a patient with a 16-year history of intrathecal Baclofen pump therapy for spastic tetraplegic cerebral palsy. He presented to the emergency department with an acute onset of bradycardia, respiratory depression, and altered mental status. The initial cause of the patient's presentation in the ED was believed to be an intrathecal Baclofen pump malfunction. This led to delays in care for the true etiology, which was the patient's obstipation. This case represents a common anchoring bias that medical providers erroneously believe due to a patient's intrathecal Baclofen pump use. To give a little bit more background on the patient involved in this case, he was a 23-year-old male with a past medical history of spastic tetraplegic cerebral palsy and was treated with intrathecal Baclofen for the past 16 years. A Baclofen pump refill was performed 11 days prior to the ED visit without complication. The patient experienced a sudden change in mental status observed by his mother, at which time she called the emergency medical services. EMS observed the patient at the scene with bradycardia, hypotension, and respiratory depression. In the ED, he was observed to have acute hypoxic respiratory failure, respiratory depression, altered mental status, somnolence, bradycardia, and hypotension. The patient was in the hospital for a total of 8 days. On day 2, he was transferred from the ED to the ICU and was started on IV antibiotics for potential pneumonia and starecrotal colitis. He was also continued on pressors to maintain his blood pressure. On day 3, an aggressive bowel regimen was started to alleviate his obstipation. On day 4, the bowel regimen led to the resolution of the large rectosigmoidal stool burn that he had been experiencing. On day 5, his obstipation had completely resolved and his mental status had improved. He was extubated due to the improvement in spontaneous respiratory function. On day 8, the patient had returned to baseline and was discharged home. It is important to note that noxious stimuli such as obstipation, urine retention, and pressure sores are a more common cause of complications in patients with cerebral palsy requiring ITB pumps than actual ITB pump malfunctions. Most reported ITB pump complications include infections up to 1 month after pump placement, and pump failures such as catheter fractures or kinks up to 72 months after pump placement. A study published in 2014 at the Cleveland Clinic demonstrated that complications are common in the months directly after pump placement, but then decline in frequency, becoming negligible at 72 months, as seen in the graph on the left. Our patient was far outside this range when he presented to the ED. The most frequent presentations of an ITB pump failure are not specific to ITB pump malfunctions. The most common complications are hypotonia, somnolence, convulsions, nausea, vomiting, and headaches, all of which can be seen in many different disease states. ITB pump malfunction and improper refilling of an ITB pump are the major causes of withdrawal or overdose. Refill of an ITB pump requires inserting a 22-gauge needle through the skin and into the fill port, as seen in the picture. The excess Baclofen remaining in the pump is first removed, and then the correct amount is added to the pump. There are 2 possible major errors that occur when refilling a pump with Baclofen. First is missing the fill port, leading to what is called a pocket fill, where the Baclofen is accidentally injected into the surrounding tissue. Because the Baclofen dosage is only useful in the intrathecal space, the Baclofen is not a high enough dose to have any actual effect, leading to withdrawal. The other potential error is injecting into the catheter port, leading to a massive influx of Baclofen into the intrathecal space. It is important to note that a 22-gauge needle is always used in this process, and only a 25-gauge needle or smaller can enter the catheter port, making this mistake impossible if using the proper needle. This patient's hospital course represents the danger of the anchoring heuristic associated with intrathecal Baclofen pumps. In this case, the ITB pump was ruled out as the cause of the patient's symptoms 24 hours after his initial presentation. The patient's obstipation, which was the true cause of his symptoms, did not begin to be treated until day 3 of his stay. The initial bias that the patient's ITB pump was the cause of his symptoms likely factored into this delay and led to a longer hospital stay. If the cause of this patient's symptoms had a higher morbidity or mortality rate associated with it, this delay could have led to a more severe outcome. Thankfully, the patient's obstipation was discovered and was able to be treated, leading to full resolution of his symptoms back to baseline. Medical providers must be careful not to immediately blame a patient's pump for their medical presentation. Further research is necessary to determine how prevalent this mistake is in the medical field, and further education of medical providers on intrathecal baclofen pumps and their potential complications is necessary to decrease the prevalence of this mistake. Thank you.